in your day in court. And make sure, and I know you all have been trained to write in a squiggle which nobody can read, get someone to transcribe your notes. We're in the age of computers. Create a database, update, pay a good young man or woman who can keep your records when you don't have the time between patients, so that you will not be in court telling me that, well, you know, I think I remember, will not be good enough. But when you're saying, you know, to the judge that this is in fact what they agreed to, this is the record that, this is a scan from X-ray, this is the record from the pharmacy, and these are my notes. You're an ideal client for any legal professional. The other thing that I would like to encourage you, and I'm glad that we have doctors and everyone from the entire healthcare tree, is that create a good team around you. The case of the forgotten antibiotic, if that doctor had a good team around him, someone would have picked out that there was no antibiotic prescribed. Talk between yourselves. Let the right arm know what the left arm is doing. Create that synergy between you, because then you have your checks and balances within your team. And remember that these are the people who will come to court and say, no, he did this, he signed here, I saw it. Or I heard him say this, and therefore I noted it down. Of course, if you have hostile relations with your team, and you lord over them because you're the surgeon and they're next to nothing, nurses or technicians of little importance, that is the scenario you're going to have in court. So be mindful of the team that you have, and later on I'll talk about leadership, because that is who you are if you're the doctor or the team leader or the senior nurse in that. Make sure you create that, because it will help you. It is part of your risk management team. Okay. Now the other thing that I do want to point out is the concept of vicarious liability. You may have seen in the papers, and because it's in the media, I think we can discuss it without the risk of being sued for defamation or slander. There, I picked up a newspaper 2 weeks back when I was here before I went back to Joburg that I think there's a case in Botswana where two doctors were fighting. I don't know how that happened, but it happened, and a patient died. And lo and behold, the attorneys for the hospital are saying this doctor is not an employee or has nothing to do with the hospital. And I said to myself, do you allow strangers to just walk in, do a procedure, and walk out? I mean, come on. I know this is Botswana, but that's a stretch, all right? And just looking at it, I said, isn't their lawyer talking to them about vicarious liability? And this is what I mean. Because you as a consultant may have admission rights at a hospital, you have a relationship with the hospital, the patient has a relationship with you. After all, the patient is lying on their bed. You don't come in with your own bed, right? They're taking medications that are in the pharmacy in that hospital. The patient, when you walk out after doing a procedure, is taken care of by nurses and other professionals who are hired by the hospital. I believe Okamosu hires its own nurses. Those of you who might be going there with patients, you don't come in with your own team. I mean, it's not a hotel that you would come in and go out and have barely anything other than lying on the bed and drinking the water in the hospital. Therefore, there is a responsibility and therefore a duty of care by the hospital as well. This is the extent of the level of care and vicarious liability. If I went to Bokamosto today, and I've been there, it's a beautiful physical structure. If I went there and I was taking yogurt to a patient friend of mine, and I dropped the bag and the yogurt poured on the floor, and I just cleaned with some tissues, but I didn't get rid of the wet stuff, and a patient walking by tripped and fell, trust me, the hospital is vicariously responsible and liable for that patient. That is the extent of vicarious liability. So for those of you who are in private practice, Even if I trip coming into your clinic because you forgot to put the little sign that says mind your step, if I break my leg and I'll just come in to have a very simple procedure done, guess what? You now have to take care of my knee and probably pay me for it. That's vicarious liability. If the cleaner in your clinic, in your hospital, does not dry up the floor or put the yellow sign that says wet floor, with a little man who is about to fall or in the process of falling, if you don't put that sign, guess what? You are liable for the patient if anything should happen. Therefore, when I talk about a team, it means you as a neurosurgeon, you as a doctor, you as the nurse, head of nursing, hospital superintendent, the cleaning lady, everybody that is in that setup has a responsibility to the patient coming in and out. You cannot hide under, it is not my responsibility, or I was not part of the hospital, or that doctor does not have a contract. When we changed hands, the contract expired, they were never hired by the hospital. I have a good answer to that, and it's that you are responsible. I believe that gives you the understanding of how you're all linked, and I deliberately made the doctor a lady and put a male nurse because I see that we have a lot of gender equality in Botswana, which is a credit to the nation. I also, as a tribute to Indus Healthcare, put a picture that is one of their hospitals in India, which I thought looks pretty nice. And obviously at night hospitals look less scary than during the night. So, as I explained, there is a duty of care, standard of care that rests with the doctor, with the nurse, with the entire team, including those in pharmacy. We talked about the young lady who just simply typed without paying too much attention, and because of her negligence, the whole hospital paid the price. So what then should you do coming out of here, now that I've put the fear of God in you? The first thing, given some of the cases that we have seen, you want to know what's my legal status. If I'm working at the government hospital, do I have a contract with them? What is my level of responsibility? Who do I report to? Who is in my care, under me or within my sphere of influence? And why would you care? Because you're pegging your license, you're pegging your freedom to the team around you. Ladies and gentlemen, I have seen doctors go to jail on criminal negligence. Right now in Kenya, there is a case that we're looking at in which a doctor is going to go to jail, for sure, and probably for the rest of his life. You should not be spending your time in jail or in court. You should be spending your time in the places for which you train, and that is saving lives. The other thing that I would urge you, like I said earlier, invest in your personal excellence, invest in yourself, create leaders among you that will take this nation to another level. And I appreciate that you started that by coming to this conference. Most of you have a direct influence on the policy making of this country. Look at the pitfalls that are there that could cause the government to lose millions. If you imagine that, and we do have a case that I was consulting with one of the institutions here, where they're suing the government for 14 million. Now that's one patient. You multiply that by 10 patients, that's 140 million pula. If you were given 140 million pula today, what would you not do in changing the level of care in a particular hospital? Actually, in several hospitals. You'd be able to provide medications that maybe are not currently available. You'll probably be able to upgrade dialysis equipment that has not been upgraded because of funds. Let's not pour out government funding into settling professional negligence when that money could go into maternal health care, when it could go into better nutrition for the children, when it would go into scholarships so that we have more of you coming out into the healthcare field. And most important, invest in yourself as leaders and take on the younger generation and mentor them. Let them be better than you so that this country observes a higher level of care in this noble profession. With those very, very few remarks, I want to acknowledge the fact that between the legal profession and the medical profession, as someone said earlier, they're both noble professions. We have something in common. Dr. Betty has done well by going from just the medical to taking a look and getting some qualifications in the legal, or what we call medical jurisprudence. It's a wide field that I would encourage you, particularly I understand there are students among us. We also have nurses among us. Consider taking your background right now and channeling it towards legal understanding so that you can become advisors. You can be risk managers in the clinics, in the hospitals, at the ministry, and also go into teaching. I was talking to the University of Botswana and I realized that when you train here, healthcare law is a minuscule, has minuscule emphasis. Not much is being taught in this aspect, and yet it is very, very important that we have a clear understanding of our legal responsibility because of the authority that you have in your hands. Personally, I've been a beneficiary of the medical profession, so I have a great respect for all of you. I had 3 children through cesarean. My last one was born very premature at 6 months and 19 days. She was so little, I was like, I am not taking this child home anytime soon. So when after 2 weeks they said to me, oh, the good news, Miss Rosie can take the baby home. I said, oh, absolutely not. She is too small. I'm not taking the responsibility for this baby. And in the US, you know, if you say culture, that's the first one. They'll let you get away with a lot. I said, In my African culture, I cannot take the child home when, you know, out of the hospital within less than 40 days. And they said, really? I said, yes. And Dr. Betty, that was Duke University Hospital. I had flown from New York I was going to Florida, and so I was flying to Florida, and as soon as we reached cruising altitude, and I was reminded of that yesterday coming here from Habroni, and I think coming here because the small plane is 31,000, and there it was 36,000 feet above sea level, and I knew I was in labor, and I asked the girl, I had not really experienced labor, so I asked the lady sitting next to me, I whispered, what does labor really feel like? And she looked at me and she was like, are you in labor? And she said it so loudly that everybody in the plane looked at me. And the air hostess came and said, oh my God, please don't do this. And I'm thinking, like, I have a choice, you know? And you know, as the Lord works, there were 2 doctors going to a medical conference to West Palm Beach. And you know, Americans are really terrified of being sued. So they came and talked to me and said, ma'am, if you would sign this form, consent, we will help you out, we will be able to slow down the labor. And they did. And then of course they told the pilot who was able to radio for assistance and was told he could land within 22 minutes into North Carolina. And that's how it ended up in Duke Hospital. And of course, as you land, the ambulances are there, the fire brigade and the police vehicles. And this child was born. Of course, they slowed labor for 2 weeks. And the doctor, because, sorry, that was before the 6 months and 19 days. And they were really nice to me. I mean, you know, the medical profession is something else. I mean, things that you think cannot happen, they make it happen. And you go into triage and they talk to you. And I remember this nurse saying, look, you have nothing to worry about. And that's what as patients we want to hear. That's the power that you have to give that confidence to a patient. And so they slowed the labor for about 3 weeks. And then the doctor said, no, let's go ahead and take this baby out to where we can see her. She's not behaving very well. And the little girl was born, and they realized, of course, that she did not need oxygen because having spent 3 months in Kenya during the first trimester, I believe has an effect in that we are born with expanded lungs. For those who didn't know, I'm actually from Kenya, and that explains why our runners doing the marathons very well, you know. But now, of course, Nigel from Botswana has made a mark in that. But yeah, so this little girl, Zanani, was born with expanded lungs, and she did not need as much time in the incubator. But then she was too little, and I said, no. Culturally, we must stay under the same roof for 40 days. But of course, after about 21 days, I was tired of the hospital food and so on, and I was ready to go home. But when I say that, I tell you this story so that you can understand my appreciation of the medical profession. That here I was with a little baby knowing that she really, in ordinary ways, did not stand a chance. But because of the power of medicine, because of the level of care, and because of the ability that you all have, I now have a young lady who's 17 years old, getting ready to go into medical school as well. And I remember, going into the NICU every time, and there were all these little babies, and believe me, there were babies who were born earlier than she was. And I remember this particular child, when I left, and she, before I left, I looked one morning, and this little incubator, because when you're there all the time, you start smiling at all the babies. And one morning I came in, and this baby wasn't there, and I was thinking, oh gosh, the baby must have died. And there's the room where we used to go, the nursing to express the milk and so on. And I didn't know what to say if I ran into her. But after 1 year, this particular hospital usually celebrates has a celebration to honor the babies that survived. And so we go back for the celebration, and there are all these little babies that have been 5.5 and 6 months. And the beauty of medicine? These babies were not even being held anymore because they were a year old, and they're running all over the place. They're actually wearing shoes, and they're crisscrossing the cameras. Of course, it's a big thing. They're eating cake and pouring juice. And the joy of the mothers and the fathers, and the credit to that goes to the medical profession. Why? Why would you want to give that up? Why would you be negligent and lose that ability to serve mankind? Why would you not care about the girl who's typing your notes? Why would you not build a relationship with the person in the pharmacy so that whenever they see your prescription, they look at it and double check? Why would you not say good morning, ma, to the lady doing the cleaning so that she feels that she has a self-worth even though she did not go to medical school? These are the thoughts and these are the questions that I want to leave you with. So as you build your careers, look at the other dimension of the legal. And I pray to God that none of you will ever be termed a defendant or respondent. And in addition, don't make your ministry, don't make your government, don't make your clinic, don't make your private hospitals be enjoined with you on court records or court documents because of something you didn't take care of. With that, I think we still have about 10-15 minutes for questions or comments.
Yeah, thank you, Indus. Opportunity to welcome Dr. Sapatai with me, who's now with me in the dais, and I would like to hand over the mic to him for his comments.
Okay, thank you very much, Sally. Indeed, it was very informative that everyone, regardless of what level they are, is very important as part of the institution, from Indus all the way to the head of the institution. With the background training in surgery, I always get concerned, because most of the issues that get cited from the surgical department. And recently, because of issues of lawsuit or poor patient outcomes, I could say a lot has been done in the professions. Not only focusing on the clinical knowledge or the technical aspects, but to focus on the surgery as a public health issue. Like right now, we talk about the concept of surgical safety, and this has been come with the WHO thing, which focus on the issue of surgical safety as a public health issue. That when you get into your body, it starts building rapport with the patients, getting to the team that works with the patients, ensuring that each and everyone knows each other. And these are things that actually, should extend throughout the whole institution as a whole. Having said that, I would like to say, this is an eye-opener, because sometimes in this country, we don't consider the legal risks, especially as workers, especially in public service, as an issue. Part of it is because much of what is happening is handled by ministry. Sometimes the patient that you took care of, institutes a legal proceedings against you, unbeknownst to you, and people are not aware of that. And I think that has to change. People have to be involved in the lawsuits so that they can account and also reflect on the, if it's done mistake, they should make it a point that they don't repeat it. The concept of just handling the cases on their own, and sometimes even if you go there, the lawyers are unprepared for the case because they don't really, I don't know what is the issue. The information is not there, even though it's not missing. They just didn't take the time to go through the information, study the information, interview people. Very few people do that. So it's always a concern on my part to see that. But having said that, legal risks are always there and always be there. And fortunately in this country, some people may say it's unfortunate, but I think it's fortunate because I always see a lawsuit as a way of saying maybe you did something wrong or maybe you didn't. But whichever the case, you have to attend to it and also reflect on your day-to-day workings so that you improve the system. Ultimately, it's good because it makes sure that people are vigilant, the system improves. You also take care of the risks that you didn't know there were risks, like falling, the infrastructure, everything, even the instrumentation. So I think as a way forward, we will also consider this public health, private, whatever, that is always important that as healthcare professionals, we have to explain everything that we are doing to our patients and outcomes and everything. But also you have to look at the cultural issues. Like this morning I was listening to the morning reports. This report, this patient is on a ventilator, the pupils are fixed and dilated. So I say the patient is dead. And they said, no, I say, but practically, it's brain dead, and, what are we going to tell the family? And it's very, very important that when you do these things, you explain clearly what is happening, and we don't hide and say, people don't want to hear those things. It's very, very important for people, so they have the duty to know what is happening about their relatives. So I think these are legal issues that we do. But also, give to the rest of the floor for their comments, and, because this is a very important topic. Thank you very much.
Thank you, Dr. I'd like to just reiterate some of the few observations which were shared to us. For doctors, first I'll like to say that when you accept a patient, there arise three duties of care. The first duty of care, as Madam Rose explained to us, is to decide whether you are competent enough to take up that case or not. Once you have decided that you are competent to take up this case, the next duty of care arises, which is to decide what treatment to give. Once you have decided to treat that patient, it is your duty legally to provide the latest and the best treatment available under your means and the medical fraternity you are practicing with. Then, once you have done that, the third duty of care arises, that is to oversee the treatment. Like what treatment I have prescribed, when the treatment is being actually given, it is my duty and I am responsible legally to oversee that treatment. Even if my pharmacist is issuing me the drugs, suppose it's a chemotherapeutic drug, which are very highly dangerous drugs, it becomes my duty also to counter check whether the right kind of drug has been issued, whether it is expired or not. When my nurse is giving that particular medicine, is she giving it in the right manner prescribed? If I said it has to go intravenous, whether it is going intravenous or not. So just writing the prescription and forgetting about it, we are doing medical negligence. So three duties of care arise whenever I accept any patient or any kind of treatment. Then the second thing I like to address nurses here, that like medical profession, even the law is ever evolving, it is ever changing. As we learn about what is happening around, the new laws come. And I'm sure in a few years, Botswana is also going to be, very medically active, because that is the trend around the world nowadays. Now the important point I'm going to make here for the nurses is that they are also equally responsible as medical healthcare professionals. So, when, like Dr. Sipakai said, he mentioned about the surgical checklist. So when the patient comes, suppose onto the operation theatre, it becomes your legal duty nowadays. I mean, if you want to say, as she said, we should have evidence. This is one of the evidence that you delivered your level of care to what's desired. So surgical safety checklist, we must be very diligent and religious in filling it out very carefully. Then, if you are a circulating nurse, you are equally liable in counting the number of instruments. Sometimes, there have been a lot of lawsuits where people have forgotten scissors inside or something. So, as a circulating nurse, you are even more responsible than the scrub nurse for the maintenance of the count. And of course, the head of the team, who is the surgeon, is not, he is also equally liable, but circulating nurse is also equally liable. Then another thing about the nurses is the documentation, what drug you have given, at what time, whether you check the expiry or not, whatever comes into your mind, keep on documenting everything. Because if somebody is going to sue me after 1 year, I'm not going to remember what I did that day. It is the evidence. As Madam Rose, she stressed on it again and again. It's the evidence which is going to save you. So your documentation is your evidence. Whatever comes into your mind, why you took a particular decision, why you did this, you should all keep on documenting. Then another important thing she told us about was handwriting. The notes have to be very clear and legible. If I am going to present my evidence, suppose to a judge or to my lawyer, he is going to read them and take out important points out of them. But if it is not legible, see, whole of the evidence, in spite of being recorded, it goes waste. So we have to be very legible whenever we write in something. It's a very, very important piece of evidence. Then I'll address the pharmacist's issuance of drugs. A lot of medical errors, pertain to use of expiry drugs. So when we are issuing drugs, we should be we should document what we have issued, to whom it was issued, who took up those drugs, and whether we check the expiry date or not. Because that evidence, if somebody sues you later on, that evidence will come handy. Another point I'll like to emphasize was of vicarious responsibility. This vicarious responsibility comes from what we call in legal fraternity as master-servant relationship. So if the Ministry of Health has appointed me to treat somebody, so Ministry of Health is my master and I am the servant who is working on behalf of Ministry of Health. So if tomorrow, if it is a private hospital, suppose, and they say, no, this was an independent consultant, he was consulting this patient in his own clinic, they just came here and we provided them just the operation theatre. Okay, that does not absolve the hospital who is the master, who is responsible for overseeing everything, of his responsibility of care. He is 50% responsible for that. Or like Madam Rose was telling, if somebody slips on the floor because the cleaner has not put up that yellow sign, the hospital superintendent is also responsible, being the master, because he is employing that particular servant. So this master-servant relationship is a very classical term used in legal fraternity. Now, another important last point Madam Rose had emphasized was that know your legal status. That if I am practicing, ensure that you are registered with. If you are not registered, no, you may be experienced for 30 years, but on a particular day I am not registered. You are failing in your duty of care. Because the first thing the judge is going to ask, the day your case goes there, they are going to ask, are you legally competent? So you must get registered. So don't ignore your registrations. Whether you are a doctor, whether you are a nurse or a pharmacist, get registered on time. With these comments, I throw this open for discussion. If you have any questions, please, we can talk to Madam Rose.
The standard of care assumes systems are in place to do certain things, whereas the duty is to attend to patients. So maybe you can throw a bit of light on it. Is one accused to recuse him or herself if he or she knows that doing certain things when systems are not in place are going to end up in a catastrophe?
Thank you. Interesting question that raises a couple of issues. Like he's rightly said, duty of care is personal. It's what you do. The standard of care presumes that everything is in place. And let's take the example where you're working in a clinic, the floor might be chipped, there is no normal saline, your syringes are not in place. Why in the world do you want to operate in a substandard setup? Part of your responsibility is to make sure not only that you're qualified, but the place you're working in qualifies as a clinic or setup that should be able to deliver the service to your patients at the best and highest level of care. So this is again putting the level of care beyond you just wanting to see the patient. It's saying first and foremost, does my typist even have a paper and pen? Is my filing record system in place? If I make notes, is there a place to file them properly? Because the law requires that the limitation of such is that within 3 years they can still sue. 2 years and 10 patients to a referral hospital or from a clinic to a hospital by ambulance. That ambulance is properly equipped with the right paramedics. All of that is part of the team spirit we're talking about. And therefore there must also be synergy between the private and the public industry. And this is where you're now I'm calling upon you to go a step further, to work with your ministry, to work with the CEO of your hospital, to make sure that everything is in place, because at the end of the day, our life depends on it. I hope that answers your question. Thank you.
court never wants you to be on the top of it. They don't want extraordinary skills. The court just says that what was the ordinary skill available at that point of time when the event happened. So that is how the court decides the standard. Thank you.
For us who keep delivering women, the standard of care would be just to bring to you what happened recently where someone gets the wrong instrument, uses the wrong instrument to try and deliver a baby. They've heard about that you could deliver a baby with this instrument. Say, nay, it's just called a forceps. Takes the wrong forceps and ends up perforating the womb several times, and the woman dies. Someone with ordinary skills in the right environment with minimal education will never push themselves to do such things. So it's part of what I'm commenting. The other thing you should really know is your limitations. Never actually push yourself to be doing things that you have no clue about. You are supposed to do a major operation. Instead, you run and close yourself in a room and you start googling how it's done, or reading a text. It's wrong. But these are the kind of things that I can't remember. My friend Johnny will be my witness in saying, I can't remember how many times we've gone to court for things like this. The other thing which I really want to emphasize is informed consent. What we are used to is just what is that for? The yellow sign here, okay, and that kind of thing. Really, what you are signing for, or what the patient is signing for, they are signing that they have understood this that you have explained to them, including what might go wrong, and they have themselves decided that despite all these risks that you have explained to them, they have decided to go ahead with the procedure. That you have allayed their fears and all that. You don't just come and say, sign here, let's go and do the Caesar and all that kind of thing. So this really is a very important session. It also includes things you touched on, Madam touched on professionalism, professional etiquette, how I appear. Doesn't really, I wonder how I would feel as a patient if I'm in and out of consciousness and I wake up, lo and behold, in front of me is this doctor who is wearing these things people wear these days. Or Tantari t-shirt, or they are reeking of alcohol, and all that kind of thing. It's not what I would conceive as a good standard of care as a patient, all that kind of thing. So, and lastly, I'm really glad, ma'am, that you've touched on vicarious relationships or vicarious vicarious liability, because we we have been dealing with, we've got a hospital model, especially in private, where the doctors create their own money. Me, as an owner of a hospital, I provide them the facilities to come and operate. And so, like in Gaborone, we've never had this kind of thing in hospital, thank God. But in Gaborone, what I've been seeing is just just in obstetrics, a bunch of doctors, everyone has got their own standard, which is no standard at all. They do their own thing, and the hospital trusts them. And whenever there is a problem, so no, we've got nothing to do with it, and that kind of thing. And I've been pushing my friend here, get a contact so she can come and address you in a room, and that kind of thing, so that all these things are put into place and people actually understand what they are doing. Thank you very much. Really, really thank you.
Okay, we'll allow 2 more comments because it's already
said that it looks like the legal aspects, the legal aspect of medical practice or nursing practice is very little on training. So when we get trained, we don't talk much about that. So that is why many times when we have to do things like incident reports, which I think talks well to the point on paper training. Incident reports is something that we are very scared of. When you ask staff to produce incident reports, many times people will be scared because they think when I'm asked to produce an incident report, it means I've done something wrong. But little knowing that an incident report, depending on the circumstances, it can actually save you from being in unnecessary trouble. And then the other thing about the paper trail is documentation. Many times, or most of the time, healthcare providers, we do a lot of good, but we don't document. So that when relatives or the patient complain that they've been neglected, you can't trace it on the file of the patient. Patients will be, or relatives will be complaining that the patient is not being tended, they are not being fed, they are not being done this and this, and you ask for the file, you find that these things are not there. And I just want to give an example of one case that if you knew about it, you can give it as an example also, where a woman was taken to the hospital. She was bleeding following 3 months pregnancy. So she was done an evacuation and she continued bleeding, so that it was necessary to remove her womb. So on waking up from anesthesia, nobody sat down with her and told her that you no longer have a womb, you will never menstruate again, you will never have children again. Whether it was done or not, nobody knows because the file could not say that. If she was told, it was never documented. So there was no proof that she was ever told. So when it is like that, then it means that the Minister of Health obviously had to play. The other thing that I want to comment about is that as health workers, many times we have this thing of we are too paternalistic. Sometimes even with consent, informed consent. I'll give you an example of lumbar puncture. You know, lumbar puncture is one procedure which should be, very basic, but for some reason the community has become so scared of it. So many times they decline when they are asked to have a lumbar puncture done. But there are some instances where the doctor, because they know that once I do this procedure, I will be able to help the patient, they go ahead and do it anyway. And then, unfortunately, sometimes the patient dies later on. Then the family will come back and say, here you are, now you have killed our patient. So in that case, Madam Rose, may you explain where the ethical dilemmas of making such decisions and the informed consent, where's the line? Thank you.
Thank you for that question and for the comments. For every procedure, for every situation, we're not going to take a stance that we're going to do this in case something goes wrong. No, it should be routine. And this is the beauty of routine. When you know that ordinarily that is what you do every single time, when you go before the judge, you can then say that in 100 cases, in 100 situations, our records reflect that we did it, out of 100 times, we did it correctly. This was just an off chance. But if you cannot say to the court and then you're showing that out of 100, 99.9 times you do it.
And you know that your duty is to protect the patient, and you have a professional know-how that this is what needs to be done. And you have people who say, no. In a child, of course, you said yes, an issue. In an adult, maybe that's the issues. Because then they will say, after 2 or 3 days, now you can do it, when the time is already gone.
Thank you. I try to limit the whole concept of the whole idea of consent, because it could go way and come a whole day. But I appreciate that clarification. Like he had said, if a child is minor, I think in this country it's 18 years, a parent will sign or a guardian. Now, if a patient comes and they're unconscious, what do? You have been given the mandate as professionals to do what is best for the patient. What is best is what, that is the key word. Did you do, given again the standard of care and your duty of care to our patients, did you do your best? But again, he said there's consent by community. You have the case of Bobby, Christina, whom we looked at earlier, and a lot of cases like that come up in the US. They're going to ask, this one is saying do this, the other one is saying no. The uncle is saying, I don't want you doing anything that is a spine, something could go wrong, you can end up with paralysis, and you're saying if we don't do it, there will be no opportunity of paralysis, in fact, it's going to die anyway. I believe that there is certain statutes, I'm not very sure about Botswana, but there in most jurisdictions that I have worked in, there is statutory provision for the doctor to do the best that you can, given certain circumstances. And that, again, is what we're saying. We must know. And if you have risk managers resident in your institution, make sure that you know what the legal provision is and what it entitles you to.
Okay, thank you very much. I will allow the very last comment. We have gone over and this concludes the first session. Over to you, Doctor.
Rose. Going forward, respiratory distress, ladies and gentlemen, is a commonly encountered problem in the neonatal period. The causes are varied, but the commonest being respiratory distress syndrome, which is a problem we often see in premature babies, which makes it hard for the babies to breathe. Enormous studies have been made in understanding the pathophysiology and management of respiratory distress syndrome, leading to improvements in morbidity as well as mortality in infants with the condition. Botswana has seen an increase in neonatal mortality in the past. According to a study in 2011, respiratory distress syndrome in newborns accounted for 8.7% of neonatal deaths, of which most of the deaths were preventable. I now invite Dr. Rachna Singh to share her views on respiratory distress in newborns. Dr. Rachna is a pediatrician who holds an experience of working in many renowned hospitals. She has more than 14 years of experience in the field a significant number of which have been in newborn care and handling neonatal emergencies. She is currently working in Letsola Pebe Memorial Hospital, Mau. To chair the session, I request Dr. Mompati, a specialist physician and a fellow of Royal College of Physicians, Scotland. He holds an MRCP diploma from UK along with a master's degree in strategic management. He is currently the head of internal medicine department in Yangawe Referral Hospital. Along with him, I request Dr. Ibrahim, a specialist in internal medicine with a diploma in anesthesia and intensive care and also on tropical diseases. He has a significant experience in pediatric care too. Dr. Ibrahim is currently also working in Yangawe Referral Hospital since last 15 years. So I request Dr. Mompati and Dr. Ibrahim to dial the chairperson. And I request Dr. Rachna to please take over.
Greetings from Mount. It's always nice to hear when Mount is mentioned in a special way. Even Dr. Sumula didn't say that. He said they're specialists even in Mount, and it gives me pride to say that I'm from Mount. I've been there for almost 2.5 years, and I'm working as a specialist pediatrician at Letsola Pebe Memorial Hospital, and I would be presenting. Can I have a little demo, please? On a neonate with respiratory distress. And at the outset, I would like to apologize if I take frequent pauses to drink water. I've just been recovering from a bout of upper respiratory infection. Dr. Sibul, I'll take your plan B tonight. Okay. So, how many of us sitting here deal with newborns on our daily, as a daily routine? How many of us deal with newborns? The causes. So I will broadly be dividing my presentation into 3 parts. The first being just running through the important causes of respiratory distress in the neonate. In the second part, I will be sharing with you a study, a retrospective study, which we did when I was working back home in India in a level 3 neonatal unit, which reviewed the various causes and outcomes of neonates who present to us with respiratory distress. And then lastly, I would just be discussing the important causes of respiratory distress in a neonate. Well, to describe respiratory distress, we all know it is the presence of more signs of increased work of breathing. And when we talk of newborns, we know a tachypnea, where the respiratory rate is more than 60 beats per minute, along with other causes, other features of respiratory distress with nasal flaring, chest wall retractions, grunting. All of this will make us realize this newborn is in respiratory distress. To run through the differential diagnosis or the causes of respiratory distress, like Dr. Divya mentioned, respiratory distress syndrome, which was previously known as hyaline membrane disease, is a very commonly encountered problem, mostly in the preterm neonate. The others being transient tachypnea of newborn, meconium aspiration syndrome, pleural effusions, pneumothorax, congenital lung malformations. Sepsis and pneumonia comprise an important cause of respiratory distress in a neonate. Congenital heart diseases, persistent pulmonary hypertension due to any cause are also primary. Blood loss or anemia secondary to any cause, as well as polycythemia, both can lead to a neonate with respiratory distress. Not to forget anatomic causes like tracheoesophageal fistula, diaphragmatic hernias, upper airway obstructions, like Pierre-Robin syndrome. All of these can cause a neonate to develop respiratory distress. Hypoglycemia, inborn errors. The study was conducted with the objective to analyze the causes, the associated conditions, the course during the hospital stay, and the outcome of newborns who presented to us with respiratory distress. As I mentioned, it was conducted at the Apollo Hospital in New Delhi. It was a retrospective study conducted between the period just mentioned on the slide. It might look a little ancient, but the most of the causes they still remain the same. And at this point, we might even think of conducting similar studies within the country here, maybe in the referral centers or the bigger hospitals, which could help us get an overview of the commonest conditions of newborn respiratory distress. All the newborns who presented to us with respiratory distress were included in the study, and those which expired within the first 24 hours of life and those with congenital malformations were excluded. A total of 346 newborns were included, out of which 39% were inborns and the rest were delivered outside the hospital. 61% of the babies were delivered by cesarean section, the rest were vaginal deliveries. An important point which came out during the course of the study was that 15%, which is a very high number if we compare it to the incidence of birth asphyxia in the Western world, which is just about 1 to 1.5%. So 15% of our babies had severe birth asphyxia, scoring an APGAR of less than 4. This is a breakup according to the sex. The males outnumber the females. The incidence of respiratory distress according to the gestational age, 34% of the babies were delivered above 36 weeks of gestation, and 30% of them fell between the gestation age of 28 to 33 weeks. According to the birth weight, more than 51.1% of the babies were weighing above 2,000 grams, and 24.5 were weighing between 1,000 and 1,500 grams. This slide shows us that 67.9 of the new were ventilated and the rest were non-ventilated. And the duration of ventilation was more than 48 hours in majority of the neonates. The common causes of ventilation that were analyzed during the study was, that should have been RDS actually, were respiratory distress syndrome in 27% of the neonates, followed closely by persistent pulmonary hypertension, birth asphyxia, pneumonia, pneumothorax, sepsis, meconium aspiration syndromes, and others. All of our babies who had respiratory distress syndrome were administered surfactant, and most of them did well with just a single dose of surfactant. A few of them needed the second and third dose as well. Coming to the other group, that was the babies who did not require ventilation. In that group, the commonest cause was transient tachypnea of newborn, followed by sepsis and pneumonia. This is a diagram showing the same transient tachypnea, followed closely by septal arteriosus, intraventricular hemorrhage. The mortality of the babies with respiratory distress syndrome was almost 31.1%, and 13% out of those eventually went up to develop a chronic lung disease or bronchopulmonary dysplasia. None of the non-ventilated babies, however, expired. So, the conclusion of the particular study was that respiratory distress syndrome, previously known as hyaline membrane disease, is the commonest cause of respiratory distress requiring ventilatory support. And transient tachypnea of newborn is the commonest cause in non-ventilated babies. From here, I will briefly be discussing the common causes enlisted in that the first few slides, where respiratory distress syndrome was right on top, and of course we can't do without talking of respiratory distress syndrome when we are talking of respiratory distress in a neonate. In fact, I think that terminology is so common that many a times I have medical officers and nurses just admitting even a term baby with respiratory distress as respiratory distress syndrome. So, respiratory distress in maternal history as in terms of preterm labor, any evidence of sepsis, any evidence of chorioamnionitis, intrauterine stress, anything, all of that is important along with a detailed examination. Blood gases are very typical, which show low oxygen and acidosis. Those of us who have seen babies with respiratory distress syndrome must be familiar with the X-ray picture, which is a typical ground glass or reticulogranular pattern that we see in a neonate delivered born with respiratory distress. This one. That's an air bronchogram. That's a prominent air-filled bronchi, which is also commonly seen in babies with respiratory distress. The second X-ray is a complete white-out lung, which we say, which is just a complete ground glass or reticulogranular pattern. Not to forget the other laboratory tests that we need to do to rule out infection, because as I mentioned, sepsis is a very important cause of respiratory distress. So your routine FBC blood cultures need to be done as well. Supportive care is of prime importance in managing any neonate. A calm, gentle setting, maintaining the temperatures, and judiciously managing the fluids, where we have to be careful about not causing fluid overload leading to pulmonary edema, as at the same time making sure that we have an adequate cardiac output.